We have a green backdrop.
Yes.
Smells.
My lady, may I please call Judith Paget, who can be sworn.
Repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
I'm sorry if we've kept you waiting.
No, it's fine.
Paget.
Thank
I
you.
suspect you've been here since this morning, haven't you?
I have, my lady, but it's absolutely fine.
Were you
Thank
here
you.
when I arrived?
I was.
Well, I'm really sorry that you waited so long.
No problem.
Your full name, please.
Judith Ann Paget.
Mrs. Paget, you have provided 2 statements to this module of the inquiry. For reference, they are INQ 000486014 and INQ 000485240.
That's correct, Mr. Mills.
You are the CEO of NHS Wales and the Director General of the Health, Social Care and Early Years Group.
That's correct.
The latter was during the pandemic, known as the Health and Social Services Group.
It was.
A little bit about your background. From June 2014 to October 21, you were the CEO of Aneurin Bevan University Health Board,
Correct.
after which in November 21 you were appointed as the interim CEO of NHS Wales,
Correct.
a role to which you were permanently appointed in June 2023.
That's correct.
Can we start, please, with the data NHS Wales received about COVID-19 infections and deaths during the pandemic? Let us deal with NHS staff first. At paragraph 448 of your statement, you say that the Welsh Government regularly received data on the number of NHS staff who were absent for reasons due to COVID-19. But that data did not, however, record whether the member of staff had contracted COVID-19 whilst at work. Is that right?
That's correct.
In the same paragraph, you say the Welsh Government does not hold or publish official or verified data on the number of NHS staff who died from COVID-19.
That's correct.
Please can we have a look at INQ 000475209. This is the statement made by Professor Clower on behalf of Glangwili General Hospital, who the inquiry heard from yesterday. At paragraph 50, we read that the hospital experienced 1 staff death attributable to COVID, which was acquired within the community and not whilst at work. Before I ask you about that, let us also look at INQ 000480136. This is a statement from the University Hospital of Wales, and at 62, we read that the Health Board is able to say that they sadly lost 6 members of staff who died following contracting COVID-19. 3 of those worked at the hospital, 1 a surgeon, 1 a theatre assistant, and 1 a nurse. It's a small sample, of course it is, but it would appear, would it not, that staff deaths were being recorded by the local health boards?
So I think my view would be that at a local health board level, they would know whether they'd lost members of staff, and that would be correct. What I understand to be the case was that there was no official mechanism for the number of deaths to be recorded and reported officially to Welsh Government and recorded on a Welsh Government system. My understanding is that Welsh Government relied on the ONS data in order to advise them on the number of health and care workers who lost their lives during the COVID-19 pandemic.
We'll look at the ONS data in respect of patient deaths in a moment, but can I ask you this, please? Do you see the absence of an official mechanism for the number of deaths to be recorded and reported officially to the Welsh Government as being a serious issue?
So I think my view would be that the ONS data capture is a well-established and reliable mechanism for recording information. And so I can understand completely why Welsh Government at that time relied on that as the evidence source. I think that in future arrangements, it clearly would be helpful to know and understand the impact and recording of staff impacted by COVID-19 or any other pandemic. But I think that what would be really important to understand is the reliability of that data, because clearly organisations will be reporting their understanding. You might have a member of staff in your organisation who sadly lost their life in a community or in a neighbouring health board. So it's really about making sure that any data capture system can be relied upon.
Can I ask you about patient deaths?
Yeah.
At your paragraph 450, you say that the Welsh Government did not produce its own COVID-19 mortality data during the pandemic, instead relying on two sources. What were those two sources, please?
The one source was a data capture that Public Health Wales had introduced. And I recall this because obviously previously I was the Chief Executive of an Iron Bevan University Health Board. I recall that Public Health Wales asked us to ensure that on a daily basis we completed a pre-prescribed form to provide them with details of any person who'd died in our care in the previous 24 hours, which we did, and sent that to them on a regular basis. And then the second data capture was again the ONS survey data.
Can I just ask you about the first, then we'll come to the second. It's right, is it not, that the rapid surveillance data,
Yeah.
what the first was called, suffered from systematic underreporting during the early stages of the pandemic?
I can't comment on that. My experience in the health board that I worked in at the time was that we made absolutely rigorous efforts to ensure that the data was captured and verified and submitted. I can't comment on what happened with other NHS organisations.
I'm just at your 454, and of course appreciating that you've had assistance in drafting this statement, but we do read first sentence of that paragraph: systematic underreporting in the Public Health Wales rapid surveillance data was identified during the early stages of the pandemic. Are you able to share with us any of the reasons identified for that underreporting?
I'm afraid I'm not. It would be speculation on my part if I did.
The ONS data then, can you help us? How did that come to the Welsh Government?
I didn't work in Welsh Government at that time, but our statistics team get regular feeds of information from accredited sources, one of which would be ONS.
At your 456, you explain the ONS mortality data is based on death registrations and coroner's reports.
Yes.
At 455, above it, you explained that it was published on a weekly basis. Was there a disadvantage in having that data only as regular as every week?
So my understanding, based on the explanations that I was given at the time, clearly not in Welsh Government, was that Public Health Wales wanted a more timely reporting of deaths in NHS facilities, and that was why we were asked to do the rapid surveillance and submit that on a daily basis.
Can we think then about your time as CEO? Soon after your appointment in November 2021, you were tasked with leading the response to the Omicron variant.
Yeah.
Reflecting on that time now, did you have the data you needed at your fingertips in respect of NHS staff who contracted COVID-19 at work, staff who died from COVID-19, and patient deaths from COVID-19?
Going through the three, I would have relied on the ONS data in relation to patient deaths. We had a regular feed of information from the NHS in relation to staff absence, including staff absence from COVID-19. We would not have had data about whether or not COVID-19 had been contracted in a work situation or in a community situation, because it was impossible to know that for sure.
Yes, understood. Can I ask you this, please, before looking forward to improvements or changes that have been made? When you arrived in post in November 2021, were you surprised to discover that this data was not being actively collected by NHS Wales itself?
I did ask questions about data availability. Clearly, I was given the information that I've just relayed to you, and I accepted those explanations from colleagues around making sure that the data we had was from a reliable and validated source. So I accepted those explanations.
Can I ask you then, what has been done to improve the collection of data in Wales in readiness for a future pandemic?
So in relation to patient deaths, then we would continue to use the ONS data, and there has been no changes to that. In relation to staff health and sickness, we are implementing a new electronic staff record that would allow us to have a more reliable capture of information in relation to staff well-being and sickness absence levels.
Next, please, palliative care.
Okay.
At paragraph 382 of your statement, it's page 134, Mrs. Paget. I'll let you get to it.
Okay. Bear with me, sorry.
Take your time.
Did you say 382?
It's paragraph 382, yes.
I've found it, thank you.
You say the Welsh Government required that palliative and end-of-life care in all hospital settings must continue during the pandemic. And you go on at 383 to say you are not aware of any specific reports which were brought to the attention of the Minister for Health regarding any failures to meet this requirement, or of any particular instances of COVID-19 patients failing to receive palliative care.
That's correct.
I'd just like us to look at two documents and consider how reassured you are by the absence of specific reports to the Minister that palliative care was not maintained. The first, please, is INQ 000182461, document titled Maintaining Essential Health Services During the COVID-19 Pandemic, Summary of Services Deemed Essential. If we move to page 22, we find a section on palliative and end-of-life care. From the fifth line down of this paragraph, we read, access to admission for palliative care purposes where necessary, to inpatient specialist palliative care expertise, and to palliative interventions should be preserved where it is possible and safe. This must be judged according to the local context. Do we understand from this that the instruction gives the local health board, or even a hospital within the board, discretion to decide not to admit a patient for palliative care if it is deemed not possible, not safe to do so?
That would be the interpretation of that in practice, based on my own personal experience, of course. Our teams would have done whatever possible to meet the wishes of a patient and their family in terms of palliative care. So absolutely, clearly, if there were situations where it was judged to be unsafe for that individual to be admitted, then clearly they would have made arrangements to have appropriate and effective care in another setting. But the wording of the paragraph suggests that.
Yes. Can we look, please, at INQ 000 469 089? This is an email chain from February 2021. It doesn't involve you, it involves your predecessor,
Yep.
Dr. Goodall. But it considered a number of lessons learned in respect of palliative care. If we look at the paragraph beginning key lessons learnt,
Yes.
in the second sentence we read this: most palliative care units are not well set up to control transmission. Can you just help us understand this observation, please? Is this a comment on perhaps the size of most palliative care units, the level of ventilation?
Yeah, I mean, the palliative care units will be located in local hospitals, so any implications around the condition of that estate, the availability of ventilation, etc., would impact on palliative care units in the same way as it would impact on other parts of the hospital.
6 lines up from the bottom of this paragraph, we have this: we know a bit more about what really matters. Parentheses, good medical care, good symptom control, but also individualisation, human presence, and flexibility in approach. And what doesn't? And I'd like to focus on this: being too risk-averse to protect ourselves. Now, if we recall that access to palliative care depended on a local assessment of whether it was safe, does what we read in this paragraph give rise to concern that people were not always provided with palliative care because the units were not well set up to control transmission, and there appears to be a recognition here that those managing the units have on occasion been too risk-averse in order to protect themselves?
I'm not sure I can comment on that because I don't really know what was in the thinking of the person when they committed that to writing.
This is an email chain from February 2021. Can you help the inquiry? Have there been any other reviews into lessons learned in respect of administering and maintaining palliative care during the pandemic?
Yes, certainly. We have established a national programme, a forum that brings experts, clinical experts and patients and their representatives together to understand what worked well and what didn't work so well during the pandemic. And as a result of that, a quality statement has been published by Welsh Government, which clearly sets out what good looks like for palliative care in Wales. The person who drafted this email is actually the National Clinical Lead for Palliative and End-of-Life Care in Wales, and is a key contributor to that work. Also, if I could say that as a result of learning during the pandemic, the Welsh Government included 2 commitments in their programme for government which related to palliative care. And one was to ensure that we reviewed hospice funding in Wales. And as a result, we provided, Welsh Government provided additional resource, but also that strengthened focus on palliative and end-of-life care should continue. And as a result of that, investments have been made in additional specialist clinical nursing staff to work on weekends, additional district nurses to support people at weekends as well. So there has been learning, but also changes made as a result of that.
Can we move to DNACPR, please?
Okay.
it's right, is it not, that Wales has its own policy in this area? That's the All Wales DNACPR policy.
That's correct.
DNACPR decisions being a clinical one, can you help the inquiry understand what the purpose of the All Wales policy is?
So the purpose of the policy is to set out a very clear framework to guide clinicians in the application of DNA CPR in Wales. I'll come back to any subsequent questions that you might ask me.
The version of the policy in place at the start of the pandemic was the 2017 policy.
That's correct.
That was updated in 2020.
That's correct.
Can you help us with when in 2020?
I think it was towards the latter half of the year, but I would have to check the accuracy of that.
And it was updated again in 2022, by which time you were the CEO of NHS
That's
Wales.
correct.
How is this policy disseminated to local health boards in order to ensure consistency of approach in this area?
So we have a national group that oversees the development of the policy and all subsequent materials to support the implementation of the policy. That group will disseminate the revisions to the policy or any changes to forms, documentation or advice to every NHS organisation. The group have also provided educational materials, seminars, training to care homes, staff training modules on our electronic training records. There is e-learning elements as well, and all of the materials, both the policy and the supportive materials and video explanations and advice is all on a single website available to everybody.
Are you aware of the concerns that have been raised by both patients and those who lost loved ones about DNA CPR practices during the pandemic?
I am aware, yes.
And that those concerns, as the inquiry has heard, extend to DNA CPR notices being issued in a blanket fashion to, for example, fit and healthy disabled people of working age, notices being issued without consultation with either the patient or a family member, and that there were instances of DNA CPR notices being confused with do not treat notices?
I am aware of those concerns.
I'd like us to consider then what has been done in Wales to try to get to the bottom of this issue. Can we go please to INQ 000 485929? This is the review performed by Healthcare Inspectorate Wales. It was performed during 2023 into DNA CPR decisions, and it was published earlier this year.
I believe so. I thought it was published in October 23, but I would need to check that.
Can I ask you this, please? Did NHS Wales commission this review? And if not, how did it come about?
I think it was requested, so I think we requested that Health Inspectorate Wales undertake the review to inform the ongoing learning and understanding around DNA CPR policy and application in Wales.
If we turn to page 11, please. We have an explanation of what the Healthcare Inspectorate did. Under scope and methodology, we read at the first bullet point that the review considered DNA CPR forms submitted by the health boards themselves. Then, second bullet point, further DNA CPR forms were read and compared to clinical records on site. That was at 2 health boards. Mm-hmm. We know from elsewhere in the report that a total of 280 forms were reviewed, 66 of which were the ones reviewed alongside clinical records. looking at this list in respect of the forms, it doesn't appear to say here that the forms reviewed were ones that were in fact completed during the pandemic. Are you able to help us?
I'm sorry, I can't, no.
Do you agree that it doesn't make that clear?
I do agree.
From the bottom of this page, we learn that the Healthcare Inspectorate launched 2 surveys, one for staff and one for patients. We have, under the staff survey, a total of 65 responses. And in response to the public survey, a total of 32 responses. Taking all of this together, a total of 97 responses to the surveys, 280 forms chosen by the health boards, 66 of which were reviewed alongside clinical records. No indication on the face of it that the forms reviewed were in fact completed during the pandemic. Given the scope of this review, has it allowed NHS Wales to gain a comprehensive understanding of DNACPR practices in Wales during the pandemic?
So my view would be that it is one element of a contribution to that understanding. It doesn't stand alone, and it doesn't stand as being the total work to review this. My understanding is that every NHS organisation is required to do its own local audits of the application of the DNACPR policy, and that's undertaken by local resuscitation teams. It's further my understanding that quite recently a event was undertaken to review DNACPR, to undertake a thematic review where all the learning from those audits was brought together.
I'll ask you about those other reviews in a moment, if I may. Can I first ask you about 2 recommendations that did come out of this review? Please can we go to page 7? First paragraph, starting on the 5th line down, we read this. We found some forms and clinical records either contradicted each other, were incomplete, or there was no evidence that a mental capacity assessment had been undertaken and without rationale. We are therefore not assured, based on the records we reviewed, that the DNACPR decision-making process is always completed in line with the All Wales policy for patients who were deemed to lack capacity. This issue must be addressed by the health boards and the trusts. Notwithstanding that last sentence, can I ask you this? What, if anything, has NHS Wales done in response to this particular finding?
So further audits have been undertaken and shared across Wales. The learning from this report, alongside learning from other reviews undertaken, has obviously been taken into account with a subsequent change to the policy, which is about to be issued. But I do know that further letters were sent to NHS Wales organisations, drawing to their attention the concerns around those particular things, particularly the signing of forms, the making sure that forms were legible, and to make sure that in the local audits that were undertaken, that attention was paid to these particular issues.
Last thing from this report, then, please. Can we go to page 37? At the bottom of the page, where we have the bullet points, the Healthcare Inspectorate recommended the creation of an electronic repository of DNACPR decisions. We have 3 benefits here: improved documentation of key clinical details about the DNACPR decision, in one accessible system, immediate notification to ED staff when a patient arrives in an emergency, immediate notification if a DNACPR decision is cancelled. Over the page, to add to these 3 points, we have risks they say would be mitigated by an electronic repository, the need to document additional information in clinical records, physical loss of DNACPR forms, other healthcare providers not being alerted to a DNACPR decision. Can I ask you this, please? Has NHS Wales created or indeed begun to create an electronic repository of DNACPR decisions?
Welsh Government accepted that recommendation as having strong merit. Work has begun to understand how that might be developed. I don't have any further information on the progress to that.
You have referred to other reviews having taken place in this area. Could you share with the inquiry, please, what those reviews considered and any findings that you consider the inquiry ought to hear?
So the NHS Wales Executive brought together colleagues from across NHS Wales to develop and consider the themes coming from those local audits. They brought together cases from January 22 to January 23 and shared the results of their local audits with each other. The work also included feedback from the Medical Examiners Service in terms of their review of nearly 7,000 deaths, picking up, again, those themes that related to DNA CPR that featured in about 3% of those reviews. Again, the themes were consistent with some of the things that you've mentioned earlier. So forms not being signed in the correct place, sometimes not completed, and sometimes the information about the nature of the conversations with families that had taken place not fully documented. So that was one, and a number of recommendations have been made from that, which will then feature in the updated DNA CPR policy that's currently being reviewed. And then the other one was the end of programme learning report on nosocomial transmission in hospitals that was published earlier this year. Also considered DNA CPR and took some of those thematic reviews as well. So those are the three: the HRW report, the mortality review, thematic review, and the end of programme report.
I'm sorry to intervene, but so you obviously got plenty of evidence that things aren't going right, and you need to do something. And you've had the recommendation that Mr Mills has put to you that you say has been accepted by the Welsh Government about an electronic repository,
Yes.
Which might avoid these things happening and make life a great deal better for the families of people upon whom these notices have been put, and indeed for the patients themselves. But when Mr Mills asked you what's been done to create it, you said the Welsh Government's accepted it.
Yes.
But then you used this expression, work has begun to understand how that might be developed.
Yeah.
That doesn't sound very specific to me. And what I'd like to know is, what do you mean by work has begun to understand how that might be developed? What has happened, as opposed to having reviews, meetings, plans? I want to know what's actually happened to make a repository happen.
So as far as I know, milady, it's our policy team who's supporting all the work on DNA CPR and related matters, is working alongside our digital team to work out how they can make that system happen, how it can link across NHS Wales, how it will link into existing data systems, so patient administration systems, etc., and how we can develop something that we can put in a reliable basis. What I don't know, milady, is where we are in terms of that progress to be able to report to the inquiry today.
And we have no suggested timeline?
I don't, but if it would be helpful, I can determine that after the session today and drop a note to the committee in writing.
Thank you. Sorry to interrupt, Mr. Miller.
Not at all, my lady. Mrs. Paget, can I finish with 2 questions about DNACPR? Can I ask you this? Does NHS Wales have any plans to commission a wholesale review of DNACPR notices issued during the pandemic, which currently remain in place, in order to determine whether those notices are appropriate?
So I'm not aware of any indication that a whole-scale review is required or requested. The DNA CPR policy, as I understand it, not being clinical, gives clear advice and guidance to clinicians as to the regular updating and check-in with patients during normal clinical contact around their status, whether anything has changed, and gives advice on the updating of those as needed.
Thinking then about advanced care planning perhaps more widely, can I ask you this? Has NHS Wales given consideration to adopting the Respect form in order to ensure consistency with many parts of England and Scotland?
My understanding is that the Advanced and Future Care Planning group that I mentioned earlier considers regularly what has come out of the Respect process and takes that into consideration when determining whether further reviews are needed to our current policy. My further understanding is that the Resuscitation Council of UK have indicated that they do not think the form is a DNA CPR form, but actually a form for recording decisions. The view of the group in Wales, which is made up of lots of clinical professionals, is that the DNA CPR policy that we have in Wales, the advanced care planning form, and all the other things that we have in place meet the needs of Wales, but clearly recognise that they need to draw on the widest possible advice to make sure that we keep up to date in terms of learning everywhere.
Next, please, can we consider what NHS Wales has learnt about the healthcare inequalities that were exacerbated during the pandemic? First, this, please. What work has been performed in order to understand the unequal impact of the pandemic in Wales?
So you will know from my statement and evidence from other colleagues that the focus of Welsh Government was very much on the impact of the pandemic on Black, Asian and minority ethnic groups. And a specific group was established by the First Minister that then resulted in 2 specific pieces of work. One looking at the socio-economic impact, particularly looking at structural racism and the part that that continues to play in the lives of ethnic minority people in Wales. And the other one was the workforce risk assessment. Both of those pieces of work, particularly the socio-economic subgroup, made a number of recommendations for us in the Health and Social Services group. I think there are 7 listed in my statement. 6 of those were enacted and completed at the time. There is a 7th piece of work that is ongoing, which relates to racism and general issues related to the inequalities in health that exist across Wales. So pieces of work that have been done in relation to that relate to trying to improve our data collection systems, which have been not helpful in understanding those particular issues in relation to inequalities.
Before you tell us how data collection has been improved, can you help the inquiry understand how NHS Wales's understanding of these issues has been limited by an absence of data?
So I think many of our data collection, or information systems, I'll use that word, many of our information systems have not traditionally collected ethnicity as a part of routine data collection. So we have done some audits to look at where there are gaps, and we are trying to work at the moment to close those gaps in a number of service areas. But clearly the work around the All Wales Race Equality Plan, in which the NHS has clearly an important part to play, is fundamental to that. And there are a number of service areas that we focused on, particularly maternity programmes. We've just done some work on the inequalities and outcomes of our cancer services. We've looked at childhood vaccination, and clearly we've looked at COVID-19 vaccination from an equality point of view as well.
You say work is being done to close the gaps.
Yeah.
Do I take it from that the gaps have not yet been closed?
No, they have not. They have not been closed. So we've looked at, I think it's 43 different service areas in terms of a whole range of indicators. As you might imagine, so age and sex is well represented in the data systems, but ethnicity probably represented in about 2/3 of the data systems. And we need to find a way of reliably capturing ethnicity data, and we are exploring at the moment whether the work that we have done to introduce an NHS Wales app in Wales might be a reliable way of asking patients to submit ethnicity data into our NHS system.
Can you help us? When did problems with data in this particular area come to the attention of those in senior positions at NHS Wales?
So I think clearly the COVID-19 pandemic shone a light on that, but prior to that there had been work undertaken by Welsh Government, clearly before my time, but I am aware of it, in relation to race equality action, and that has continued. I think what the pandemic has done has tried in some way to speed up the work on that, create a different imperative, one that everybody recognises, and focus the attention on the things that we can do to try and tackle some of those issues.
Speed up, but from what you say, if there were another pandemic tomorrow, data collection on inequalities would remain insufficient.
So it has improved because people are now much more aware of the need to collect that level of data. So new data systems are included in it, but clearly we have to go back and redress the gaps in the data systems that already exist. So there has been progress, but absolutely more progress is needed.
New topic, please. The challenges the hospital estate in Wales presented to the implementation of IPC measures. Can we start in this way? Insofar as generalisation is possible, it may well not be. Are you able to characterise the age of the hospital estate in Wales?
I would describe it as very mixed. So in my own health board, or the last health board I worked in, we had a brand new hospital that opened in 2020 that had 75% single rooms, and 2 hospitals that had opened in 2010 and 2012 with 100% single rooms, and all the things that go alongside that in terms of ventilation, etc. And then we had one other hospital that was built and became a hospital in the late 1890s, and everything in between. So with variation, I would say, and very mixed.
Please, can we return to the Glangwili General Hospital statement? That's INQ 000 475 209. Thank you. I'd just like to run through some of these issues that the statement sets out in respect of the hospital estate acting as a barrier to the implementation of IPC guidance. And as we go through them, I might just ask you, Mrs. Paget, to help us with the extent to which these are issues you recognise.
Okay.
Wards and corridors being narrow and not having air conditioning or filtration systems.
Yes,
Limited number of side rooms.
definitely.
Staff rooms too small for social distancing.
Yes.
Next, please, back to the University Hospital of Wales. That's INQ 000 480136. Reading, please, from paragraph 152. No on-ward staff changing facilities. Limited control over entrances and exits for staff, patients and visitors.
Yes.
No formal ventilation, apart from a very small number of isolation rooms, such that only natural ventilation, open windows and doors, is available, making it difficult to comply with IPC guidance in extreme weather.
Yes.
Recalling your time as CEO of Aneurin Bevan, are there any other challenges that you might add to this list?
I think that's a comprehensive list as far as I can remember. Yes.
Can we next look at INQ 000 396261? This is a ministerial briefing dated 15th of November 2020, clearly before your time as CEO of NHS Wales. If we can move to page 8, please. Under bed spacing, we read this. The required 3.6 metres between beds has not been fully implemented across Wales due to the consequence required of removing significant bed numbers. 2 examples are given. 98 beds would have had to be removed at the Royal Glamorgan Hospital and 110 at the Princess of Wales. Do we see here the hospital estate presenting health boards with a difficult choice between treating more patients or putting more space between them?
I think it was a very difficult choice for people to make. Clearly, there were other choices to be made in terms of securing other capacity outside the hospital. So we did commission additional beds from the private sector. And we were, in some parts of Wales, able to secure step-down beds provided through field hospital type arrangements and secure beds elsewhere. But yes, it was a difficult choice. And I see the paragraph refers to the use of perspex screens between beds, which I know was provided in some parts of Wales as well. But yes, it was difficult.
Looking to the future then, and appreciating that a hospital estate cannot be transformed overnight, what changes have been made, or indeed will be made, to the hospital estate in Wales so that it can better implement IPC measures in a future pandemic?
So this year and for the previous 2 years, we have made funding available to address some of the issues related to ventilation in hospitals. So my understanding is that an allocation of £34 million was made available in 2021-22 and in the subsequent years to address some of those issues, advised by our engineering experts in the shared services organisation that supports all NHS Wales organisations. Other things including oxygen supply, and water systems have also been included in that. So that's one. Clearly, consideration needs to be given to any new build facilities, particularly hospitals, to consider maximising the number of single rooms available. It was an issue prior to the pandemic in terms of the isolation of patients with infections, and clearly it was a considerable issue during the pandemic. But I do know that the most recent hospitals built clearly have got an increased number of single rooms, which is a very positive feature, and I know has had an important impact on hospital-acquired infections as well. So.
Next, please, can we consider concerns around the communication of IPC guidance? Returning, I think for the last time, to Glangwili, that's INQ 000475209. At paragraph 92, we have the observation that national guidance contradicted professional guidance. And the example given here is about whether FFP3 masks should be worn during CPR. We read in the final sentence, this was not an isolated incident. Do you recall from your experience as a CEO of a health board that there were times when there was a difference between national and professional guidance?
I do recall, I can't recall the specifics, but I do recall that there were occasions where there was a contradiction in guidance received by the health board.
Do you have any reflections to share with the inquiry on how such contradictions might be avoided in the future?
I think it will be really important for UK, so the three devolved administrations and UK government, to work together as they have been in relation to the PPE policies, but also have very early engagement with the professional bodies so that we are seen to be working together, and so that we don't get to the situation where we have contradictory and different advice going out to the NHS, one through professional organisations and one through the government systems.
If we look at the following paragraph, that's 93, we have this. A problem in Wales was that Public Health England guidance was usually announced on a Thursday, but guidance from Public Health Wales the following afternoon, Friday. This caused an unnecessary level of anxiety for staff, aware through the media of the PHE Thursday guidance, but unsure whether or not these changes would be effective in Wales until the following day. Can I ask you, was this issue of publication on two separate days ever resolved during the pandemic?
I don't recall it being resolved, but I do believe it became less of an issue. So my recollection is from my days in Aneurin Bevan is that at the very beginning of the pandemic it was problematic, but actually as soon as we developed ways of working and understood that the guidance for Wales would come out on a Friday, and as there was more conversation between the NHS and Public Health Wales and Welsh Government about what might be in the new guidance when it came out on a Friday, it became less of an issue, but it was an issue at the very beginning.
Do you think that in a future pandemic, English and Welsh guidance ought to be issued on the same day?
That would be very helpful if that were possible.
Next, please, the statement of University Hospital of Wales, apologies, INQ 000480136. We have this at paragraph 148. The fact that the national guidance changed so often led to a lack of confidence in some of the guidance. Was this a sentiment you were aware of during your time at Aneurin Bevan?
I was aware of the frequent changes in the guidance. I don't recall any concerns being raised with me about lack of confidence in the guidance. But the frequent changes were raised, and I was aware of that.
You were then the recipient of guidance.
Yes.
You are now on the send side. In your view, could the communication of changes in national guidance during a pandemic be improved, or are frequent changes a necessary consequence of the rapid development in understanding of a novel virus?
So I think at the very beginning it was, as you suggest, that understanding of the virus in all its forms was changing rapidly, and therefore the guidance had to change. I think that that did become easier as time went on. And as I said, the most important thing is that there is a regular dialogue between Public Health Wales, Welsh Government and the service, so that when the guidance does arrive, there are no surprises in it, because the communication of guidance and ensuring that everybody is cited on it is a phenomenal task for organisations to do. So that earlier we have notice, or organisations have notice of what's likely to be in there, the earlier they can start getting ready for the changes.
Next, please, visiting restrictions.
Mm-hmm.
Please can we look at INQ 000 469846. This guidance was issued in November 2020. At page 2, please, under background, reading from the third paragraph, we have this. The Welsh Government reiterates that the guidance sets out the current baseline for visiting in Wales during the pandemic. It goes on in the next paragraph to allow healthcare providers to depart from the guidance in response to either rising or falling levels of transmission in their local areas. I realise this is a single piece of guidance picked out, but can I ask you this? Is this broadly reflective of the Welsh approach to visiting? That is, to allow local health boards flexibility in applying visiting restrictions?
So my understanding was, by this point in time, November 2020, there was some clarity from Welsh Government around guidance on a more relaxation of the restrictions that were put in March 2020. So clearly there had been learning from that, and Welsh Government were clearer about expectations in terms of maternity, neonatal care, and obviously end-of-life care, vulnerable adults, children, etc. But I think they recognised that the people who were best placed to understand the balance of risk between visiting and potential acquisition of COVID-19 through visiting and transmission were the individual organisations, so health boards and trusts. And so certainly by that point, I think whilst encouragement from Welsh Government was to ensure that we were receptive to visiting and did whatever we could, the decision making around that assessment of risk was left with organisations.
At your paragraph 395, that's page 138.
Yep.
You refer to the exceptionality clause, which allowed local health boards to agree to visiting requests outside of the guidance, where the benefit to the well-being of the patient or visitor outweighed the infection control risk. Did this approach create inconsistency between local health boards in allowing visits in certain circumstances?
I think it may well have created a difference, but I think there would have been difference anyway, because even in my own health board, we had different situations in different hospitals at different times, which we were trying to reconcile. And so even in my own health board, there would have been differences. So absolutely across Wales, yes.
So that's different situations between different hospitals.
Yes.
Can we go to page 120 in your statement, paragraph 327? You refer, Mrs. Paget, it's on screen, in fact,
thank you.
If that's better.
Thank you, yes.
You refer to, and I'm in the first line, other exceptions, and these are in respect of visiting restrictions in March 2020, in fact. Other exceptions were at the discretion of the ward sister / charge nurse or manager with advice from the IPC team. Mm-hmm. Did this discretion risk the creation of inconsistency within the same hospital because charge nurse A might approve a visit on Monday, but charge nurse B could reach a different view on the Friday and refuse a visit?
On the same ward, I would expect the same and similar assessments, but clearly a situation could change from a Monday to a Friday. There could have been an outbreak, there could have been something else that impacted on the ward. But I think the issue is about the justification of the decision, and clearly the infection prevention control team were given consistent advice across the organisation, so they were in some ways able to try and do that consistency check on behalf of the health board.
Can I ask you this then, please, about the approach to visiting generally? In your view, should visiting restrictions aim to be, as far as possible, consistent nationally, or do you endorse allowing for a more local approach?
So I think there should be consistency around what we deem to be essential visiting. As I mentioned, there are some key groups that based on our learning during the early part of the pandemic, we would want to have moved away from the very restrictive approach we had in March to the more supportive approach we had in November. I think it would be very difficult to have an approach that was absolutely consistent at all times, at all days, in all wards, in all hospitals, because there will be variation in terms of the situation on that ward at that time.
You mentioned consistency for key groups.
Yes.
Can I ask you to share some examples of who those key groups might be?
So for maternity and neonatal services, I would, based on our learning and understanding, include partners from antenatal care all the way through. Clearly, end-of-life care was seen as essential from the beginning. Vulnerable adults, people who act as carers for others, and clearly children in terms of parental support as well.
Final topic before perhaps we take a break, Mrs. Paget. Long COVID.
Okay.
The inquiry's long COVID experts, Professors Breitling and Evans, summarised the Welsh approach to providing long COVID treatment as delivering these services not through specialised clinics, as in England, but through primary care. Is that a fair summary?
Our long COVID service is an integrated, multi-professional, community-focused rehab model with the ability to refer people to specialist clinics if they need to, or specialists, I should say, if they need to.
But it's right to say, is it not, that Wales has not adopted the specialised long COVID clinics that we see in England? Is that right?
That's correct.
Professors Breitling and Evans told the inquiry that there is now evidence that specialised long COVID clinics are both clinically and cost effective. Not asking you to comment on that. Can I instead ask this? Since you became the CEO of NHS Wales, has consideration been given to establishing specialised long COVID clinics?
There has been a constant evaluation of the model that we have in Wales. It is compliant with NICE guidance. It fits the geography and the spread of the services and population of Wales. We are regularly reviewing the evidence from research and trials as it becomes available. And at the moment, we haven't been required to change our position, but clearly if new evidence comes to light that is material, then clearly we will consider that in full.
What particular support is offered by NHS Wales to healthcare professionals with long COVID in order to assist them in returning to work?
So the long COVID support for staff is organised and available through our occupational health services. As far as I am aware, there is no specific range of services available consistently across Wales, but clearly occupational health support is available to everybody.
Looking to the future then, what can you tell the inquiry about NHS Wales's plans to continue to treat those suffering with long COVID and research?
Welsh Government has made ring-fenced money available to ensure that people who need access to long COVID care and support are able to do so. That investment has increased in the last financial year. We have been, as I said, evaluating the current long COVID service, including a significant focus on what patients are reporting as their positive outcomes. We will continue to review that and continue our commitment to providing support to long COVID patients in Wales.
Finally, this then, please, based on what has been learnt about treating long COVID, does NHS Wales have a plan in place to make sure that in the event of a future pandemic, it is able to rapidly respond to the long-term consequences of whatever that future pandemic illness may be?
I do not think we have a plan at the moment, but I do think as part of our ongoing pandemic preparedness, we do need to think beforehand of what service models might need to be put in place, either to respond to the long-term impacts of a viral illness, if that's what it were, or also to rapidly work with UK government on rapid research into what might help respond to any underlying health conditions caused by whatever the nature of any virus might be.
My lady, would that be a convenient
Of course,
moment?
I shall return at 3:10.
All rise.
Ms Mills.
My lady. Mrs. Paget, turning to lessons learned and recommendations. At Annex A of your statement referenced INQ 000485240, you set out the reviews that have been performed in Wales into matters within this module's scope. To summarise, there have been a number of reviews conducted by different organisations into distinct areas of the pandemic response. Is that a fair summary?
That's correct.
So to give some examples, we have the Equality Local Government and Communities Committee reporting on inequalities. We have Audit Wales performing a review into procurement and supply of PPE. And we have the Healthcare Inspectorate Wales producing a review into how healthcare services maintained patient safety during the pandemic.
Yes.
NHS Wales has not, however, produced a single overarching report into the pandemic response in Wales, like the one produced by NHS England in 2023. Is that right?
That's correct.
Do you consider that NHS Wales has a duty to produce a single, comprehensive report to enable it to identify and reflect on the lessons to be learnt from its pandemic response?
So my view is that there have been, as you say, you've listed some, but there have been more reports into how both Welsh Government and NHS Wales managed the response to the pandemic. There was a formal review undertaken by the Health and Social Services Group that included input from NHS organisations and social care into the response that was done in August, September 2020, and then again in 2021. That made a number of recommendations around on lessons learnt. We have followed those up and closed off now all the recommendations, so everything has been complete. The last outstanding recommendation was the establishment of the NHS Wales Executive, which has now been established.
I'll ask you about that in a moment, Mrs.
Okay.
Paget. Can I ask you this? Are you confident that the various patchwork of reviews performed has identified together all of the lessons to be learnt from the pandemic response in Wales?
So I am confident that it has. I'm confident that organisations have learnt individually. What we are now going to be doing, and I know you want to ask me about the NHS Wales Executive, but just in response to this question, we are now going to be reviewing all of the plans that NHS organisations have updated following their own learning lessons and reflections. We will review those both individually with organisations and collectively through the NHS Executive. And if there are any further learning or lessons that we need to address, then we will do so. Also to say that in the last 4 weeks, I did bring the chief executives of NHS Wales together, along with some of their senior team, plus the team that I support in Welsh Government to review the Module 1 report, but also that did give us an opportunity to gather some further reflections from organisations as well on some key things. So that does exist. If you would like me to submit that to the inquiry, I could do that.
You have, as we've moved through this afternoon's topics, shared lessons and recommendations. Can I ask you about lessons in respect of some discrete matters, please? First, 2 matters that Dr. Goodall, your predecessor, was asked about this morning, who said that you may well be better placed to answer. First, what, if any, lessons have been learnt about the use of field hospitals, please?
The last review of field hospitals and lessons learnt was done in March 21. I am not aware of any subsequent reviews or lessons learnt since Dr. Goodall left the role and I took over.
Are you able to share with the inquiry any of those lessons?
I can make them available. I don't have them with me, but I can do that.
He was also asked about bereavement services.
Yes.
By reference to the report produced by the Nosocomial COVID-19 programme in March 2023, which identified that bereavement services I apologise, final report produced in August 2024, in fact, identifying that bereavement services should be proactively signposted and offered to all families experiencing grief following the loss of a loved one. Help us, please, how is the NHS currently ensuring that such services are being proactively signposted and offered?
So during and since the pandemic, a national bereavement pathway has been developed by the NHS in Wales. It's a consistent policy and pathway that all organisations are required to implement. Every organisation now has bereavement services in place, and the executive teams of those organisations are charged with ensuring that they monitor, evaluate and get feedback on the effectiveness of those services. Also, you will know that, as you mentioned, the Nosocomial transition programme, end of programme report also makes specific comments on this, and I will be receiving a quarterly update on the implementation of the recommendations in that report to ensure that that is being followed up.
Aside from a quarterly update, what is the NHS Wales doing to ensure that these services are being changed in accordance with the report?
So the pathway is there. There is a requirement to implement it. Additional resources have been provided to organisations to make sure it happens. And as I've said, organisations themselves should be ensuring that that pathway is followed, and they regularly review that it is. And they will then report in to us through that mechanism, as I've just mentioned, with quarterly reports coming to me.
There have been several reviews into the supply of adequate PPE during the pandemic. I won't ask you about each of those reviews individually, but perhaps this, please. Can you share with the inquiry the key lessons that have been learnt in respect of ensuring an adequate supply of PPE?
So my general reflections on PPE supply, based on my experience in an Iron Bevan, was that Wales managed to ensure a good supply through procurement arrangements put in place by NHS Wales Shared Services. I don't recall any difficulty around the availability of PPE during the pandemic. But clearly the important thing is that we're really clear at the beginning the roles and responsibilities of UK versus devolved administrations. In Wales, it was agreed, or across the UK, it was agreed that devolved administrations would procure and supply their own PPE during the pandemic. And once that decision was made, I think the system was quite effective. So the most important thing is we're really clear who's doing what.
Staff well-being, please. What has NHS Wales learnt about the effectiveness of measures taken to support the mental health of staff working during a pandemic?
So I think the pandemic shone a light on something that was already receiving attention, but actually the impact on staff well-being from working during the pandemic has been immense. And so the investment that's been made in additional services, both at a local organisational level and obviously on across Wales level, has been well received, well evaluated, well supported, and our staff unions very positive about both the impact it's had and obviously the need to continue that. I think alongside that, as well as the psychological well-being of staff, it's really important that we continue to develop our occupational health services to make sure that we're able to support staff with the physical impacts, but also clearly long COVID, as we've discussed as well. So there is a balance to be struck, not only around the psychological well-being support, but the need to make sure our occupational health services are well resourced as well.
Can you tell the inquiry, please, about the structural changes then that have been made to ensure that NHS Wales can be more agile in its response to a future pandemic?
So there have been changes made within the Welsh Government group that I'm the DG of. We have created a public health directorate with additional resource and focus to ensure that we're continuing not only to focus on our pandemic preparations, but also responding to individual issues as they arise, as they have even since the pandemic. We have also embedded learning from the technical advisory cell, so making sure that we're able to develop our own modelling and reviews of evidence and linked through to research as well. So we have a small core of people now who support us with modelling data, most recently modelling what this winter might look like in terms of infectious disease. We've also created an ongoing commitment with Swansea University to help with that modelling data as well. We've provided additional support for the CMO with a second deputy CMO for public health. And we have, outside of government, created an NHS executive by bringing together functions that already existed in NHS Wales to create a critical mass of individuals who can support us to deliver on ministers' priorities and policies, and ensure that the policy objectives of Welsh Government are consistently implemented across NHS Wales. As part of that, I would say that we have created a new team within the executive, which will have responsibility for emergency planning, preparedness and response, and will coordinate and bring together and provide assurance on the plans of individual NHS organisations to make sure that we share good practice, quality assure the plans, but also support the testing of those plans on a frequent basis.
Have any of those plans yet been tested?
There was a tabletop exercise done a couple of months ago in relation to some of the plans, and also in preparation for the preparedness around mpox. There have been further testing, reviews of isolation rooms and other things which are related to preparedness for that.
Finally then, are there any lessons which I have not yet invited you to comment on that you would like to share with the inquiry?
I think we've covered most of them during my evidence, thank you. The only other one that I would probably add in relation to infection prevention control, as well as ongoing investment, which I've mentioned, and single rooms, which I've mentioned, is to make sure that we can agree a core specification for an optimal infection prevention control service and team, because I was very struck during the pandemic that although we'd invested considerably in our infection prevention control team, they were stretched considerably, incredibly busy, worked incredibly hard, but there is something to make sure that we're all working to a consistent standard. Other than that, we've picked up visiting, we've picked up palliative care and all the other things I was going to mention. So thank you, Mr. Mills.
Just finally, please, on the core specification, can you help us, perhaps by way of example, of what that might include?
So I think it might include the competencies and capabilities that you might need in your infection prevention control team and service, what the role of a consultant in infection prevention, consultant nurse in infection prevention control might look like, their job content, and what the makeup of the team might be, and what resources do they need access to in terms of training, development and ongoing support.
Mrs. Paget, thank you, my lady. That's all I ask.
Thank you. Miss Waddow, over that way. Mrs. Paget.
Thank you, my lady. Good afternoon, Mrs. Paget. I represent clinically vulnerable families, and I have some questions for you, please, regarding safe access to healthcare for members of this group. Firstly, was any specific consideration given to clinically vulnerable people who needed to access healthcare during the pandemic, and importantly, how they could do so safely?
So it's difficult to know on what basis you're asking me. So as a Welsh Government, I can't answer that question for Welsh Government. Clearly, I wasn't in Welsh Government then. But from a health board point of view, my reflection is that we worked really hard to make sure that people could have safe access to care, that we had a variety of options available to people, from virtual face-to-face to telephone access, but also if people needed to come into our hospitals, that we would arrange for them to have safe routes into hospital and be cared for appropriately when they arrived with us.
So perhaps just with your health board hat on, what do you mean, sorry, when they arrived in hospital?
So
what
if they were coming
measures?
to an outpatient's appointment, for example, making sure that they had a safe place to wait, that they didn't wait too long, that they hopefully went straight into the clinic room, they were seen quickly and supported if they needed a diagnostic test, that was done as quickly as possible, and they were supported to get what they needed in terms of medical attention quickly and then could leave.
Thank you. Moving then to the here and now, the inquiry's heard evidence from IPC expert Dr. Warne that there is an ongoing need to consider how clinically vulnerable people can safely access healthcare settings, including hospitals. Do you agree with Dr. Warne with that? And if so, what, if any, steps are being taken now to ensure that this can happen?
So I would agree that we should always ensure that patients and family ability to access safe care is a priority. I'm not aware of any specific things that are happening at the moment to support that. But clearly, if our staff are aware that somebody is clinically vulnerable or extremely clinically vulnerable, they will do their best to support them in whichever way possible.
Thank you. Next, I'd like to ask you, if I may, about the potential role of carbon dioxide monitors. And I'm at paragraph 310, which is page 114 of your statement, if that assists. You describe there a letter sent by the Minister for Health to the Royal College of Nursing after the college had asked the Welsh Government to, amongst other things, consider providing CO2 monitors in healthcare settings. This was in March 2022. The minister's letter indicated that there were no plans at that time to do so because, and I quote from the letter, different air change conditions are required in individual settings. Are you able to explain that further and to help us understand why a policy of providing CO2 monitors wasn't adopted within the NHS Wales estate, given that we know that they're a reliable measure of how well ventilated a confined space is, and therefore give us an indication of the likely COVID-19 transmission risk?
Apologies, I can't add any more clarity to than what's in my statement.
Thank you. Final question then, if I may, concerning inequalities. At paragraph 755 of your statement, that's page 279, you indicate that the Welsh Government considered, amongst other groups, the clinically vulnerable when addressing changes to the delivery of healthcare services, and also when giving input on advice and policies in the healthcare context. Are you able to help us with any specific examples of how the clinically vulnerable were considered in these contexts? And are you aware if current policy continues to be assessed for potential impacts on the clinically vulnerable cohort?
So I am aware that our impact assessments take a wide range of considerations into account. Particularly, I recall the document that was published around the pandemic next steps. And the risk assessment in there makes specific reference to clinically vulnerable individuals as being a key consideration. So my view of the impact assessments that I've seen since I've been in Welsh Government is they take quite a wide view of impacts, disability, race, etc. But where there are significant impacts on particular groups, they will draw that out.
Thank you. Thank you, my lady. Those are my questions.
Thank you very much, Ms Woodard. Mr Wagner, sitting next to her.
Good afternoon. I ask questions on behalf of 13 pregnancy, baby and parenting organisations. I want to ask you first about visiting guidance. Mm-hmm. In the visiting guidance that was brought into force in May 2022, a nominated partner was recognised as a partner in care. Do you agree this was a recognition of the essential care that pregnant people receive from their partners during and around pregnancy?
I do indeed.
And do you agree that this recognition came too late?
I can understand why the initial restrictions on visiting were as they were, because people were very worried about the safety of everybody. But I think the right decision was made to adjust the guidelines later to ensure that partners or close family members were able to support somebody through all stages of their pregnancy.
I'm sorry, that wasn't exactly the question I was asking. I was asking if the recognition that these weren't just visitors, they were partners in care, which only was added to the guidance in May 2022, more than 2 years after the pandemic began. Do you agree that that recognition came too late?
I agree that it could and should have been recognised earlier.
Yeah. You said earlier, in response to a question you were asked about visiting guidance, that maternity and for maternity and neonatal services, I would, based on our learning and understanding, include partners from antenatal care, I think probably in antenatal care all the way through. So just to clarify, your view is that partners should have been permitted to access antenatal care, so ultrasound appointments, that sort of thing, throughout the pandemic?
I mean, it's a personal view. I think partners play a really important part in supporting the delivery of care. So I would absolutely support that.
Yeah. And I mean, they're a partner in care, is
absolutely
what you agreed.
Yeah.
Neonatal visiting, it wasn't until May 2022 that directive guidance that both parents would be able to visit their baby on a neonatal ward together was introduced. Were you aware that Wales was the last of the 4 nations to direct hospitals to allow both parents to have unrestricted access to their babies on neonatal wards?
I was not aware.
Can you explain the reasons why it took until May 2022, over 2 years, to direct hospitals to allow that?
I don't think I can, to be honest. I know that the colleagues were reviewing visiting principles and took a very broad view with colleagues from the NHS around an updating of the visiting guidance and developed principles. Whether that then change to the neonatal visiting came as a result of that, I'm not sure, but I wasn't aware, and I don't know why it took so long.
Do you consider that it may have been there was a lack of priority being given to women's and maternity-related care generally that led to that delay?
I don't accept that.
Do you accept, on reflection, that neonatal visiting restrictions ought to have been addressed earlier than May 2022?
I think that given that we were reviewing visiting restrictions from a wide range of perspectives, I am surprised that it took that long to develop those changing guidance for neonatal care.
And do you think that if that partnering care change had been made earlier, so recognising partners as something more than a visitor, do you think that potentially would have flowed through to earlier changes in the guidance for visitors to those kind of services?
Yeah, what I can't comment on is, although the guidance changed in, I think you said May 22, I'm not sure what that practice was at that time. So it could have been that practice had already changed and the guidance was changing to keep up with practice, because clearly in units across Wales, we had given the ability for health boards, ward managers, etc., charge nurses to make decisions around visiting. So it could be that actually practice had already changed and the guidelines were just changed to keep up with that.
Do you have any record, or did you do any research to see what individual decisions were being taken up to then?
I haven't personally, but I would be confident that the group that oversaw the changes to the visiting guidance and the principles would have been working very closely with NHS colleagues and will be well aware of what was happening in practice at that time.
Thank you.
Thank you.
Thank you, Mr. Wagner. Ms. Hannett. Now, Ms. Hannett's over there, so please make sure your answers go into the microphone. Thank you.
Mrs. Paget, I asked questions on behalf of the long COVID groups. I'm going to ask you first about long COVID services. In the July 2022 Adferiad long COVID service report, feedback called for more medical diagnosis and testing to be available to facilitate treatment and not just rehabilitation. Service users were also still calling for dedicated consultant-led clinics, reflecting similar requests in earlier national evaluations in meetings between Long COVID Wales and the Welsh Government and a petition to the Welsh Parliament. You said in your evidence just now that Wales is not required to change its position on the provision of long COVID services from the current model to a specialist long COVID clinic model. But given the consistently large number of long COVID patients reporting that the current system is not working for them, why have you not done so?
So I think, as I said, the model that we have in Wales has been designed by senior leaders, clinicians and service providers in Wales. It's consistent with NICE guidance. It's a rehabilitative, community-based model that enables people to be referred into specialist services if their condition requires it. There have been 4 CEDA evaluations of the service, the last one being on the 14th of February 23. And although there are still concerns around the service, they do relate to things such as a medical diagnosis, which was picked up in the early part of the evaluation, that the rehabilitation was not always tailored around their own personal needs, appointments not being at convenient times, and a slow referral process. So I think that as far as the evaluations are concerned, there's still a very positive feedback from people. Clearly, there are improvements to be made. As a result of the feedback from the most recent studies, additional resources were made available to health boards from Welsh Government to make the improvements in relation to that feedback. And we have just received the health board's most recent evaluation of their local services, which are currently being reviewed. But as I said earlier, if NICE guidance changed or if the evidence becomes very strong that the model should change in Wales, then clearly that will be considered. But of course,
what I'm suggesting is that the inquiry's long COVID experts, Brightlin and Evans, Professors Brightlin and Evans, gave evidence that the Welsh model has a number of distinct disadvantages, including disconnect with secondary care and also implications for training, as there's not a group of specialists. It's also the case that 3 other nations adopt the long COVID specific clinic model. So why is, in the light of Brightlin and Evans' evidence and the approach of the other 3 nations, why is Wales the outlier?
So I think that, as I've said before, and I will continue to say, as the evidence changes, we will continue to review the model. Clearly, the geography of Wales is quite different. You know, our population of 3 million people is spread across, 8,000 square miles, trying to deliver centralised hospital-based services, specialist clinics that are accessible for people so that they are required to travel long distances to get to those services is a consideration, but clearly we'll keep the situation under review.
Ms. Patrick, can I turn to ask you about children and young people with long COVID? Again, there's no dedicated long COVID clinics or services for children and young people with long COVID in Wales. In your letter to Andrew Goodall, dated the 6th of May 2022, you acknowledge that there are a number of children presenting with long COVID in Wales and that some have very significant needs. You added that, as in the situation with adults with long COVID, children with the condition are being treated close to home wherever possible, rather than being seen in specialist clinics as they might be in England. Again, the long COVID experts have said at paragraph 84 of their report that regions with lower rates of COVID-19 and fewer patients with long COVID are likely to have inexperienced healthcare professionals, which supports the need for a virtual multidisciplinary team delivered by the post-COVID children and long people hubs. Would you agree with the long COVID experts that creating a virtual multidisciplinary team to deliver specialised care from long COVID hubs for children and young people with long COVID is advantageous, given that few paediatricians will have the knowledge and expertise to deliver specialist care? And just to answer the geography point, it's a virtual hub as opposed to one that they would have to travel to.
So we've got a long COVID pathway for children that was developed by an Iron Bevan University Health Board that has been shared with all health boards. We have done awareness raising and sessions with them to draw out how that model can be implemented. As I said, we've just had the reports in from all the health boards around both adult and children's services related to long COVID. So I'd be interested in seeing our own evaluation of that and views on the services before considering that further.
And as part of that evaluation, would you recommend that they consider the evidence that's been provided to this inquiry by Professors Breitling and Evans?
So absolutely, and only recently our strategic evidence and analysis team did a review of long COVID services and evidence. I think it was of August this year. They will do that on a regular basis. That evidence supports the group that are developing and designing the services in Wales, and that will continue. So any new evidence that comes to light will absolutely be taken into account in terms of reviewing the service on an ongoing basis.
Finally, final topic, if I may, Mrs. Paget, that's data and long COVID. In the January 2022 at Ferrier programme report, that stated that there were difficulties robustly collecting the data that would have been needed due to changes in service provided, lack of long COVID specific clinical coding, and the importance of community services that would not be captured in databases such as the SAIL data bank. Question, in Wales, was there a difficulty in relying on data drawn from the coding of long COVID in GP practices?
So I think at the beginning, my understanding is, clearly I wasn't in Welsh Government then, so I'm speaking from what I've been told as opposed to what my personal experience has been. I understand that there was some concern that the GP systems weren't recording all the cases of long COVID, but clearly we've been doing a lot of awareness raising. There is now a dedicated health pathway in Wales that is consistently applied across Wales, so the quality of the data should be improving. But again, as part of this review of the reports that have just come in from the NHS, we will also be looking at the number that are recorded on the GP systems as well.
But given that documented issue with the coding of long COVID, how can the Welsh Government be confident that it's able to assess if all of the people with long COVID who need services are able to access them?
So I think that's a difficult question to answer. Clearly, we are promoting that the services are available. The GPs are aware that the pathway is there as people engage with them. And clearly, not everybody who has long COVID symptoms has wanted to seek help, but it is incumbent on us to make sure that we continue to raise awareness about the availability of services so that they are so we are encouraging people to come forward. So I think it's about keep the awareness raising, ensure that GPs are familiar with the pathway and the services are available, and that the access to the services is timely for individuals, and that people are getting the services that they need. And one of the things that we have done is made sure that we include in our ongoing evaluation patient-reported outcome measures, so we're absolutely capturing the benefit that patients have received from the services that they've had.
Final question, if I may, Mrs. Paget. The ONS is no longer recording data on the prevalence and severity of long COVID in Wales. Can you just explain, you may well have covered this in your last answer, but can you just explain whether Wales maintains any current surveillance or data gathering of prevalence and severity of long COVID outside of the clinical coding and access to long COVID services?
My understanding is that we don't, but I would have to double check on that.
Thank you. I'm grateful. Thank you, Mary. Thank you, Mr. Lowe.
Thank you, Ms. Hallett. Mr. Thomas. Mr. Thomas is behind you.
Good afternoon, Ms. Paget. I'm representing FEMHO, that's the Federation of Ethnic Minority Healthcare Organisations. In paragraph 429 of your statement, the advisory group outline recommendations for mitigating risks to Black, Asian, minority ethnic healthcare workers, such as ensuring access to appropriate PPE and conducting regular risk assessments. I'm sure you remember that.
I do.
Can you provide specific examples of how NHS Wales ensured that these recommendations were practically implemented across different NHS Wales trusts?
So I wasn't working in Welsh Government then, so I can comment from a perspective from an Iron Bevan Health Board, if that's acceptable. So there were, as I said earlier, 7 recommendations that were directed towards the NHS. One of them relating to unfair or illegal discrimination and anti-oppressive practices is subject to ongoing work through the Anti-Racist Wales Action Plan, which I can expand on further if you need me to. The first few recommendations related to the dissemination of the risk assessment tool and encouraging of its use. And I recall very clearly that in Iron Bevan, we clearly developed our own version of that risk assessment tool quite early and made it available to Welsh Government. So by the time the Welsh Government one arrived with us, we'd already done a significant amount of work, not only through our staff group, so direct line management, but working with our staff and trade unions to actually make everybody familiar with the tool, highlight how important it was for it to be used, and made copies available electronically and on paper, and promoted the use of it through our regular communications, which were going out into the organisation probably every day after our Gold meeting. And from a Welsh Government point of view, I understand from colleagues that they did review it regularly as evidence changed around the pandemic and its impact. I can't tell you how many times it was changed, but I know it was updated.
Well, in fact, I think you've touched upon my second question. If you want to expand upon it, I'll ask the question in any event, but I think you might have touched upon it, which is, what were the monitoring mechanisms that were established to track the implementations of these recommendations, and how were these results reported and evaluated across NHS Wales and the various trusts?
So I can't recall, because I wasn't in Welsh Government then, I can't recall how it was collated across Wales. I can recall locally in the Health Board we followed both the dissemination and uptake of the tool, clearly working with line managers to make sure that people who had high scores triggered by the tool were offered appropriate support. That we had stockpiles of PPE available. We used the support of the military to ensure that the PPE was available as close to staff as possible. So we ended up putting PPE stores on all hospital sites and making them available close to primary and community services. Clearly, we established a BAME network working with our trade unions, and we continue to support people to raise concerns about racism or any issues related to oppressive practices within the NHS.
Let me move on. In your statement, you refer to the work of the socio-economic subgroup, which published its recommendations on the 25th of June 2020. And just to remind you, the subgroup report made 37 recommendations to address inequalities for ethnic minority communities during the pandemic. Can you provide us with an update on the specific actions taken by NHS Wales to improve the quality of ethnicity data collection as recommended by the subgroup, and how this has impacted health outcomes?
So one of the key things that have happened in the last 12 months is that we have developed the Workforce Race Equality Standard, and we have collected data from a variety of sources to provide out to NHS organisations information around the 12 standards that are in the Race Equality Standard. We've collected the data from a variety of sources, put it together and created standard reporting mechanisms and reports out to organisations. We did also publish a national report that is available on the Welsh Government website. In terms of following up, so as well as giving the report and the data out to organisations, colleagues in my team have met with every NHS organisation to go through the outcome of that report, the recommendations that are in there, but also as part of my role in Welsh Government, we have also been looking at things that we can do on a national basis to support the NHS in Wales. So things like how can we ensure that we have more diverse membership of NHS boards, running a shadowing programme, etc., etc. So there's been a huge amount of activity in the last 12 months.
And again, I think you may have just overlapped a little bit into my next question, which is fine. If you want to develop it, please do. I was going to ask, and how has that implementation of these recommendations been evaluated?
Of the Workforce Race Equality Standard?
Yes.
So the reports went out in September. So, the reports went out in August. The meetings with all organisations have been held during September. And I chair an Equality, Diversity, Inclusion Board. And at the next meeting, we'll get feedback from the receipt of those, the feedback and next steps in terms of actions individual organisations are taking. If I could also add that for the chairs of all NHS organisations, they have a specific objective from the Cabinet Secretary to ensure that they are paying due regard to that information and all the actions in the Anti-Racist Wales Action Plan, and they will be required to update the Cabinet Secretary at their own personal appraisals as to the progress their organisation has made.
Thank you. Can you provide examples of specific health outcomes that have improved for ethnic minority communities as a result of these actions?
So these are the ones that I've been talking about are particularly related to workforce race equality. One of the areas that we've focused on it actually relates to maternity care, and we've been working with the universities to try and increase the diversity of people who are coming forward for maternity training so that our maternity midwifery services are better representative of the communities that we serve. That is still work in progress, but it's been a really important first area of work that we have ventured into in terms of trying to ensure that services in Wales better represent the people that they are serving.
This leads me on to my next area, which is the advisory group recommended immediate action to improve ethnicity data collection quality, yeah?
Yes.
Can you just share with the inquiry what specific challenges NHS Wales faced in achieving this, and how did this impact your ability to address health inequalities for ethnic minority communities during the pandemic?
So in relation to workforce, what we have identified is quite a significant number of staff, particularly at a senior level, have not declared their ethnicity on our electronic staff recording system, so about 10% of staff. So we are working with organisations as well as responding to the findings of that report to actually ensure and encourage staff to make sure that their data is recorded on our system, because that will help. In relation to the broader data issues, I think, as I said, in response to a question from Mr. Mills, clearly data capture on some of our NHS patient systems is definitely not where we need it to be. We have taken some steps to improve it, and new data systems, new informations, such as the COVID vaccination system, clearly captures ethnicity data, but I think I would have to say it's work in progress, but it is most definitely receiving attention as part of this work.
Okay, I think you've covered my next question, so let me move on to the question after that. One of the subgroups' key recommendations was to enhance healthcare access for ethnic minorities. Can you explain the strategies that NHS Wales employed to ensure equitable access to healthcare, including culturally competent mental health services?
So I think we've got a strategic programme for mental health, and as part of their work, they have a number of areas that they're looking at, but ensuring that, again, it goes back to the diversity of the workforce, but also the training that is available to people in order to ensure that they're able to appropriately support and develop the care of individuals that they come into contact with. So as I said, there are a number of areas: mental health, maternity. We've been looking at specifically at areas around cancer services and inequalities in relation to cancer and cancer screening, and there are a number of other areas as well.
The report mentions that Black, Asian and minority ethnic staff network groups as platforms for ethnic minority staff to voice their concerns. Can I ask you this? How effective have these groups been in providing insights into inequalities within the healthcare system, and what measurable improvements have resulted from their input?
So I can't comment on measurable improvements, but clearly what we will want to see through the publication of the Workforce Race Equality Standards is a shift in those over time. So clearly they've only just been published. We would continue to expect those networks to play a full part in not only supporting the analysis and response to those recommendations at an individual organisational level, but also be working with management teams in order to determine what are the best actions to take and in what order.
Yeah. Let me come on to my
have to leave it there. I'm really sorry, Mr. Thomas. I know it's tough on all of you who come at the end of the day, but we've got a fair few questions to go through.
So be it, my lady.
I'm really sorry. Miss Samantha Jones.
Thank you, my lady. Ms Padgett, I asked questions on behalf of the Disability Charities Consortium. Now, earlier you were asked questions by counsel to the inquiry on the All Wales thematic review on DNACPR that was undertaken by the Mortality Review Working Group. And I would just like to ask you a few more questions about that review, if I may. The first question I have is, has that review been published?
I don't know. I asked the same question myself, and I didn't have an answer in readiness for my appearance at the inquiry today, but I will definitely continue to follow it up, and I can ensure that it is shared.
Thank you very much. Secondly then, seeing as we don't have a copy of that review, I have a few questions about what it specifically looked at. Did the thematic review specifically look at whether DNACPRs were used inappropriately during the pandemic for disabled individuals solely as a result of their disability?
I don't think it specifically looked at that, but I know that I have seen a conclusion in the Nosocomial programme report that said that there had been no evidence of DNACPRs being inappropriately applied. So clearly that's already documented and in the public domain, so that is documented in that report.
Okay. I appreciate you gave evidence earlier about the fact that the thematic review found that conversations had not been documented, conversations with family members and individuals. But a slight different point that I would like to ask you about is, did the review look specifically at whether individuals and or their families were actually consulted about DNACPRs during the pandemic?
So I think it would be, because it was a review of documentation, so I think it would have reviewed whether or not it was documented that they had been, and the quality and legibility of the recording of those conversations. I also know that there was a recommendation that came to say that any correspondence or written communication that they had from patients or families was also to be kept with the DNACPR form as well. So I don't believe that there were conversations with individuals as part of that particular piece of work, because it was a review of documentation.
Do you think it would be a helpful recommendation for a review of DNACPRs and the concerns that were specifically raised, specifically in relation to disabled people, should now be conducted by the Welsh Government?
I don't have a view. I think that we have done a number of reviews of DNACPRs. They have been extensive. That has included HIW, this thematic review, and again, the Nosocomial transmission group. I'm not sure what benefit there would be to a further review, but clearly if there are concerns that have come through the system to our national lead, then clearly they would be quite within their remit to do that for themselves. Yeah.
Thank you very much. Thank you, my lady.
Thank you, Ms Jones. Ms Gowman, behind the pillar.
Okay.
Thank you, my lady. Mrs Paget, I ask questions on behalf of COVID-bereaved families for Justice Cymru. Photographs were taken in hospitals within an Erin Bevan University Health Board. Some of those photographs included photographs of patients being treated and body bags. Were those photographs taken with patient consent or the consent of their family members? If not, should those photographs have been taken and published online without such permission?
So one of the conditions on any agreement for the taking of photographs was that consent was to be obtained from the patients, from members of staff or family members. If a patient was ventilated and then recovered, then the consent was to be retaken when the patient was well enough to do so. So an absolute requirement was that consent was to be sought and documented.
My lady, may I ask follow-up questions in respect to the process by which consent was obtained from severely unwell patients, patient dignity and the impact on the bereaved?
I think we've probably got enough, I'm afraid. I take the point, Ms Gow.
I'll move on.
I know I've heard a lot about this, as you can imagine, directly from Welsh bereaved.
Thank you, my lady.
And I may well hear more from...
Yes. On that basis, Mrs Paget, I will move on to discuss the National Nosocomial COVID-19 End of Programme Learning Report, which was finalised in August 2024 Now, those I represent are highly critical of what they consider to be the superficial nature of the learning points in the final report, with some significant issues, they say, being underplayed or omitted. And I'd like to touch on the process by which the report was compiled and some of the deficiencies that they have identified. Firstly, what steps have you taken to satisfy yourself that all nosocomial deaths in Wales have in fact been recorded as patient safety incidents?
So as part of this programme, as you will know, there were changes made and focus given to ensuring that all nosocomial transmissions or healthcare-acquired infections in hospital were reported through a national reporting system. So that's been consistently applied across NHS Wales.
And are you satisfied that it has been consistently applied and that all nosocomial deaths have been recorded in the way that you suggest?
I have to rely that the system has done what it's been asked to do. I understand over 18,000 cases have been reviewed as part of this process, which is a substantial number. I have to rely that the process of having a clear specification and a clear process and a consistent process across NHS Wales has meant that we have captured all cases.
But presumably this was a relatively new process. Are there no checks and balances or audits that can be carried out to verify that they've all been recorded?
So I think that I would probably need to go and check myself with those who might have been closer to the audits than I would have been, and it would probably be wrong of me to speculate. But I know that in organisations, whenever there was an outbreak or whenever anybody was deemed to have got COVID-19 whilst in hospital, there was a really clear criteria about making sure that we were clear had that been community acquired or hospital acquired, and that was consistently applied to the best of my knowledge throughout the pandemic.
Moving on then, in terms of a particular deficiency that the group has identified, do you accept that the report doesn't fully address cluster outbreaks that occurred in Wales?
So the report, as I've read it, clearly it's not a Welsh Government report. It was done by the NHS, but I have clearly read it. Does it make specific does it make specific references to clusters? But I do know that they clearly would have been investigated through the normal incident management team that investigated every outbreak, and that was based on my experience of working in an Iron Bevan.
But the report itself doesn't identify underlying causes for outbreaks, doesn't identify, for example, the effectiveness and implementation of IPC guidance and any contributory factors in that regard toward outbreaks, does it?
So it doesn't make any recommendations around broader clusters, but clearly the recommendations around infection prevention control, PPE, there's the state of the NHS estate, and all those things would be factors in any cluster outbreaks as well as individual cases.
But without looking specifically at the detail and root causes of clusters, do you agree that the learning points in the report are somewhat limited?
I think that the reviewers would have determined that the lessons learnt from clusters and investigations of outbreaks at ward or departmental level or hospital level are already captured and with Public Health Wales.
And can I ask Mrs Paget, is this report intended to be a key part of NHS in Wales's learning on nosocomial infection?
It absolutely is. It's not the only thing, of course, but it is a really important piece of work. And as I said earlier in response to a question from Mr Mills, we will be ensuring that there is follow-up within the NHS executive on this report, and that we get in Welsh Government a quarterly update on the progress against the areas identified for action.
And my final question, given that it is to play a role in NHS in Wales's learning, in light of the deficiency that I've highlighted, do you think that there's any merit in further exploration of what contributed to nosocomial infection in Wales?
So my view would be it is recorded and documented. What we will need to ensure is that as this piece of work now moves forward, that there are the opportunity for Public Health Wales to continue contributing learning as they've got it recorded in terms of that. But just to say that's been there for a little while now. It's not a new thing. So Public Health Wales will have and NHS organisations will have a lot of information around the issues that contributed to outbreaks, and clearly as part of infection prevention control policies and practices, those things will have already influenced what is happening.
Thank you, Mrs. Paget. No further questions. Thank you, my lady.
Thank you, Ms. Gammon. Very grateful. Thank you very much for your help, Ms. Paget. We've now completed the questions for you, and we didn't have to ask you to do what we asked Dr. Gould to go. We have completed you today.
Thank you, my lady. Thank you.
10 o'clock tomorrow.